Welcome back to Quick Hits in Lab Medicine. I've got 7 slides to talk about acute phase proteins, and these are commonly measured in the context of serum protein electrophoresis, but they're also measured in a variety of other conditions, and so we'll touch on a couple of those as well. So what is an acute phase reactant? These are proteins that are synthesized by the liver in response to inflammation. So tissue damage causes an acute phase response, inflammation, infection. In particular, bacterial infections, you get an exaggerated response due to endotoxin. So bacterial endotoxin is a prime stimulant for acute phase reaction synthesis. And the kinetics differ depending on which acute phase reactant you're monitoring and the disease state. And what's interesting about that is we talk about it as an acute phase response, and you would think that would mean, within days or something like that. But this also happens in chronic conditions. So in cancer that's been going on for years, you get what we call an acute phase response because these same proteins get upregulated and synthesized. So they're coming from the liver. The specificity depends on which one you're monitoring, and generally it's good for tissue injury but low for specific disease states. So you can't make a diagnosis of a specific disease, but you can say that there's an inflammatory process going on, and that's what they're useful to. So small amounts of inflammation are going to cause increases, and probably our most sensitive acute phase reactant is what we call C-reactive protein. It's generally not measured with serum protein electrophoresis because serum protein electrophoresis is a screening test looking for bulk changes in proteins, and it's simply not sensitive enough to pick up small changes in C-reactive protein. And so we would do that by an immunoassay. So our approach is we could use an SPEP to screen for major changes in protein abnormalities, and then if we're concerned about a specific protein, we target that with an immunoassay. So CRP is good for acute inflammation, and we use a SED rate, erythrocyte sedimentation rate, commonly referred to as a SED rate. And basically that test works by simply dropping a drop of blood into a tube containing fluid and measuring the rate that the blood falls. And so in a chronic inflammatory state, you have immunoglobulins that are coating the outside of the red cells, causing the red cells to stick together so it falls faster. So when we're talking about acute phase proteins in the setting of protein electrophoresis, which we have another quick slideshow on, we differentiate those into which bands they show up on the SPEP. And so the first band that they show up in is the alpha-1 band, and the alpha-1 globulins are alpha-1 antitrypsin, which is a serine protease that works to maintain the elasticity of the lungs. So it's synthesized by the liver. It's essential for lung function. It is decreased in certain genetic conditions, so alpha-1 antitrypsin deficiency. There's a variety of forms of that. Can be picked up by basically a flat alpha-1 peak on serum protein electrophoresis. Again, if we suspect an alpha-1 deficiency, we can use an immunoassay and quantify directly how much alpha-1 antitrypsin is present, which is a bit more accurate as far as is a lot more accurate as a quantitative test. So if you have a deficiency, so if you have an alpha-1 antitrypsin deficiency, that's associated with emphysema and liver disease. The other alpha-1 glycoprotein that's important is alpha-1 acid glycoprotein. Really, it's a binding globulin for many different things, and in particular, a lot of drugs bind to the alpha-1 glycoprotein. The alpha-2 band consists of primarily haptoglobin, and really haptoglobin's function is to bind free hemoglobin. And when it binds free hemoglobin, it gets catabolized by the liver, and so your haptoglobin decreases. In the setting of an acute phase response, it's bacteriostatic, and so it makes sense that it would be elevated. We measure it commonly in clinical practice as an indicator of in vivo hemolysis. So basically, if you're lysing red cells, you're going to release hemoglobin. That's going to bind to haptoglobin. The haptoglobin is going to be catabolized by the liver. And so in that case, you're going to get a low haptoglobin. And again, we would do that with an immunoassay as opposed to serum protein electrophoresis. Cerulplasmin is a copper binding globulin. We think about it in terms of Wilson's disease. It's related to uptake of iron and metabolism of iron. So those were the alpha-2 globulins. In the gamma region, so that's the last region of the SPEP that we're going to spend a little bit of time talking about, primarily consists of immunoglobulins. CRP does come out there, but on a serum protein electrophoresis, you don't have sufficient sensitivity to pick up CRP. As we said, it is our most sensitive acute phase reactant. It activates complement and starts the immune complex cascade. So we do measure it for progression of disease. Is disease resolving? There's a different form, a different assay. It's the same molecule, but it's a more sensitive assay. We call it highly sensitive CRP, and we use that. Some people use that as a diagnostic or a prognostic marker for cardiovascular disease. Really, it's talking about inflammation at low levels, which leads to plaque formation. The other acute phase reactants, or the other gamma globulin molecules, are our immunoglobulins. We have 5 different ones: G, A, M, D, and E. And primarily we would be picking up G, A, and M. The last acute phase reactant I want to talk about is procalcitonin, because it's used a little bit differently. It's not measured with a standard serum protein electrophoresis, but measured by immunoassay. So we need a sensitive test, and immunoassays are a lot more sensitive than serum protein electrophoresis. So we quantify it by an immunoassay, and it's really a good marker of bacterial infection. And so it's been used in the setting of antimicrobial stewardship. So if you treat someone and they come in sick and you think it's an infection, and you put them on antibiotics to start with because they're so ill, if their procalcitonin is low, then maybe that's an inappropriate use of antibiotics, and instead of giving them the full 10-day course or 2-week course of antibiotics or whatever you're going to do, you can use procalcitonin as a means to help justify not needing antibiotics. So generally they don't go up in viral infections, and they're really most useful for respiratory infections. So after successful therapy, your PCT is going to drop, and again, that can be used as a guide to helping stop antibiotics when they're no longer needed, instead of just finishing out the course. It has a half-life of about 24 hours, so when you successfully treated an infection, you want to see it dropping by about 50% over each day. And again, that's one of the ways that it's used in antimicrobial stewardship. So that's a quick discussion about acute phase reactants, and we'll cover serum protein electrophoresis in a little bit more detail in our next section. Thanks for tuning in.